going to talk about modes of ventilation. Bismillahirrahmanirrahim. We have a lot of modes of ventilations, but we'll start talking about controlled mandatory ventilations from the volume controlled type of ventilators. We have volume controlled, as I've mentioned before, pressure controlled, and we have the pressure controlled volume target. Now I'm going to talk about controlled mandatory ventilations from the volume controlled type. We have mentioned before that the mode of ventilation is formed of a constellation of control variable, phase variable, condition variables, and the waveforms. So this mode, which is controlled mandatory ventilations, will entail data from these control variables and the data from these phase variables and the apnea, it is an apnea mode for sure, and data from this psi, and what about the time of the waveform used in this mode of ventilation. Also, before we talk about the controlled controlled mode of ventilation, or this volume controlled ventilation, it is we have mentioned before that this is the earliest type of ventilator, which we call the volume controlled ventilation, in which we have mentioned that this is a formula. This is a compliance equals the tidal volume over the plateau pressure. We have, this is a fixed part. It is compliance. This is physiological or pathological. We do not do any for it except we treat it, but it is not a ventilatory maneuvers. So what we play with is, or what we change is the tidal volume of the plateau pressure. In this case of volume controlled ventilation, so we fix the tidal volume, and according to the compliance, the plateau pressure will be developed. So if the compliance is large, so the plateau pressure resulting from this fixed tidal volume will be small. Say if this is the compliance is 50 ml and the tidal volume is 500, so the pressure will be 10 centimeter water. On the other hand, if the reverse happens, that the compliance is bad, it is less, it is small. In this case, the tidal volume is fixed, so this pressure will be high. It is the tidal volume is the same, like 500 as I mentioned before, and the compliance is 25, so this will increase, and instead of being 10, it'll be 25. So this is a should be considered. Here, this controlled mandatory ventilation, this is volume controlled. What about the controlled variables we supply the ventilator with? Or in this mode of ventilation, which is controlled mandatory ventilation, volume controlled, we set the flow, but mainly we set the volume, and we set the flow, or we set the time, either the flow or the time. If we say that this is if we tell the ventilator, please, you should deliver 500 ml to the patients. In what time? In 0.5 seconds. This means the flow will be like that. Will be, say, about 120, right? 120 liter per 120 liter per minute. This means that 2 liters per second, 1 liter. No, it will be 60 liter per minute. 60 liter per minute means that 1 liter per second. So 500 will be delivered in 0.5 seconds. Same thing if you apply it. Please, I want the flow to be 60 liter per minute, and the volume is 500. The time will be 0.5 seconds. So we set tidal volume and either flow or time. Sometimes you do not put flow, neither flow nor time, but we put the IE ratio. We're going to talk about it. The pressure in this case, no, we put the tidal volume, and the flow delivered for the delivery of this tidal volume in that time, according to the compliance and resistance, will develop pressure. So the pressure is not mine, it is the result of this flow and compliance and resistance. So this will be an alarm. I said phi2 for sure, and how frequent per minute. This is the respiratory rate. When it comes to the triggering, this is controlled. The patient paralyzed. The patient does not take his breaths. There is no spontaneous breathing. The patient is not. The patient is paralyzed or under muscle relaxant. So the triggering will be time. You give an order to the ventilator. Please, the rate is 15 breaths per minute. This means that every 4 seconds, if every 4 seconds, the ventilator starts to give the breath. So the triggering is time. Rising time, there is no rising time. It is effective flow. The limit here, the limit, this is the pressure. It is the pressure which is the net result of the flow through the resistance and compliance to get this pressure. So it is an alarm. It is not a limit which should not be exceeded as in case of pressure control. Cycle of here, the cycle, the inspiration is terminated for sure after delivery of the preset tidal volume. Inspiratory pause, you can put it. We're going to talk about it. Beep, you can put a beep or not. And apnea mode, as a backup, no, this is an apneic mode. So there is no need for apnea mode. Psi, you can put a psi. Waveform is rectangular. We are going to see. This is how, that's it. These are the data which you should supply to the ventilator. So the ventilator will set the flow, volume, or the volume with the time, or the volume with the IA ratio, Fi2, respiratory rate. Triggering, this is the time, the triggering, the limit is the pressure, and it is an alarm. Cycle off by the tidal volume, interspiratory pause, you put it, or BB, but no apnea mode. This is an apnea mode because it is a controlled mandatory ventilations. When you come back again to specify this type of ventilator, it is volume controlled. Type of respiration is mandatory. Control variables, we set the tidal volume of flow, tidal volume in spot time, or tidal volume with IA ratio. Pressure is limit. The triggering is time. This is the pressure is this is the target. No, this is the respiratory rate, and if I2 you put it. This is the first variable. The triggering is time. The limit is pressure, which is an alarm. The cycle is after the delivery of the tidal volume. Inspiratory you put it or not. BB you put it or not. The apnea data, this is an apneic data. There is no apnea data because this is mandatory. This is controlled mandatory. The psi, you can put the psi. This is the data for controlled mandatory ventilation. Again, when you come to look at these waveforms, like this is a pressure time curve. This is a flow time curve. This is a volume time curve. When you look at this is a pressure time curve. This is a pressure. Here, this is the starting the pressure through the flow of air through the bronchial tree to give you the pressure resistance. And then inflation of the alveoli. This is what will give you the plateau pressure or pressure elastance. And this is a peak pressure. If you put an inspiratory pause, this is the time. So this is the peak pressure, and this is a drop of the pressure when you put an inspiratory pause. This means that after delivery, you'll stop inflating the patient by stopping inflation through the inspiratory limb. No more flow. So the pressure resulting from the flow through the bronchial tree, which is the pressure resistance, will be 0. And you are measuring now the plateau pressure, which is the pressure inflating the alveoli. This is the pressure. This is what we call the plateau pressure. And after that, you open the expiratory lamp, so there is a deflation. And come back to the starting point, whether beep or 0 point, which functions the capacity or above it in case of beep. Look at the flow. The flow is a fixed flow. This is a flow. It is a constant one. Say you said that this is the flow is 60 liters per minute, so it goes rapidly to the and maintained at 60 liters per minute. So this is the maintenance. This is maintained at 60 liters per minute. And after the delivery of the tidal volume, no more flow. So the flow is stopped. So this is a flow, no more flow. And here this is a pressure to pressure. The flow, no more flow, it came back to 0. And this is the time lag for the inspiratory pause. And after that starts the expiratory flow. And the expiratory flow will for sure will start from the pressure plateau pressures and then go. This is a flow which is an passive one, and this depends on the resistance, expiratory resistance, and the compliance of the patients, and takes its time in what we call expiratory time constant. When it comes to the tidal volume, this is inflation. This is the tidal volume, preset tidal volume. This is the preset. This is the level of the tidal volume. This is start from 0 to this value, say 500. And then the tidal volume is trapped in the lung during the inspiratory pause, and that's it. Soon after that, you deflate it. Came back to 0. From this point, which is 500, will be the 0 for the expiration, to come to the 500 and the expiratory, and this is the reserve. So this is the inspiratory time. And when you come to this, the inspiratory pause is included within the inspiratory time. So this is inspiratory time. From here to there, from this is inspiratory time. And this is expiratory time, including expiration plus expiratory pause. Can't you see this? This is the problem. This is the normal. Look at this. This is this controlled mandative ventilation. There is no triggering here. This patient is paralyzed or a muscle relaxant or paralyzed by some other pathology. So this is the peak inspiratory pressure. This is the pressure resistance. This is the plateau pressure due to the inspiratory pause, and then this is expiration. When you come to the flow, this is rectangular. This is a fixed flow, maintain 60 liter per minute or whatever it is. And for this time, inspiratory time, till the delivery of the tidal volume, and after that, no more flow. The inspiratory limb is occluded, no more flow. And then we come to the expiration. Expiratory valve is opened, and then the expirations. This is the expiration. And this is the expiration. It starts from here. This is expiration. And this is expiratory time. This total expiratory time. This is an expiratory pause. No more flow, either in or out, and the patient is in a steady state. When you come to the inspiratory, this is inspiratory pause. Inspiratory pause, you put it in a time or a percent. If you are using IE ratio, this should be a part of a ratio percent from the inspiratory time. This should have a percent of the inspiratory time, and this percent might be from 15 to 25% of the inspiratory time, not the total cycle. Okay? But if you have this is not a ratio, but you are using inspiratory time, so this should be a time, and this time ranges from 0.3 or 0.2 to 0.4 seconds. This is it is important to keep in mind. If you are using IE ratio, this inspiratory time will be a percent from the inspiratory time, this inspiratory pause. If you are using inspiratory, if you are using time instead of IE ratio, in this case, this inspiratory pause will be a time 0.3 or 0.4 seconds. Look at this. That's it. Yeah, this is the setting, tidal volume. This is respiratory rate. This is a beep. This is FI2. This concentrations, and this is the IE ratio. We didn't put flow here. The IE ratio in this case, an inspiratory should be percent from the inspiratory time. This is 10% of the inspiratory time. Maximum to about 25% of the inspiratory time. Why did we put it percent? Because this inspiratory time will change. It is a percent. It is a ratio between inspiration and expirations, and according to the rate, this will change. Absolute value will change according to the respiratory rate. So in this case, this should also change according to the respiratory rate. So it is a percent of the inspiratory time, which is changeable, right? So in this case, the flow for sure will change. According, this is the time is changeable, so the flow will change. So this is a very important point. This is the triggering for this case is controlled mandated is 0. Right? Right. Look at this. This is another bar. This is it is not a ratio. When we can look at this, this is not. It is inspiratory time, and this inspiratory time we have changed it. Inspiratory time. This is 1 second. So in this 1 second, this inspiratory time is time. It is not a ratio. For sure, this flow rate will be fixed. So the flow will be fixed, inspiratory will be fixed, and it will not be the same like that a ratio, which is changeable. And at the same time, when you look, this is a time, so the inspiratory pause will be time and not a percent. It will be 0.2 seconds per say, or 0.3 seconds, or 0.4 seconds. This is a time. This is inspiratory pause will be time. If it is IE ratio, this will be a percent. That's why if it is a time, this is inspiratory time. It will be fixed. At the same time, the rest in the flow rate will be fixed, and the inspiratory pause will be fixed. But the variable here in this case will, or changeable, will be the IE ratio. Same thing, you can fix the flow rate. If you fix the flow rate, the inspiratory time will be fixed, and the inspiratory pause in this case will be time, and the changeable will be the IE ratio will be changeable. Look at this. This is a patient with IE ratio. The rate increased too much, so there is a decrease in both inspiratory and inspiratory pause. So the shape of this is the shape of the wave. If this is a time and not a ratio, this wave will be repeated the same, but with this high frequency. It will be repeated by this same figure, because it will the inspector time will be the same time, inspector time will be the same time, and the encroachment will be on the expiratory time. So the shape of this will be the same. But since it is IE ratio, there is a decrease in this inspiratory time, decrease in inspiratory pause, and accordingly also decrease in the expiratory time, and this is associated with concomitant increase in the flow in order to deliver the preset tidal volume. This is a IE ratio, but you put the inspiratory pause 0, so this is a 0. So this is a peak in inspiratory pressures, and there is no inspiratory pause, and this is at the end of inspiration, these are expirations, no inspiratory pause. Well, the aim of this mode is to deliver a fixed tidal volume to the patient. So look at this data. What about unloading the patient pump? What are the matching of the patient to the ventilator's flow, volume, inspiratory times, and oxygenations? For sure, this is a patient. This is controlled mandatory ventilation. The patient is not taking his breath, so it is mandatory. No, the patient is not breathing, so the breath is delivered from the ventilator itself. And here, this is the driving pressure. When you look at this is what we call driving pressure. We're going to talk about it separately. This is the pressure between the beep of the 0 point and to the peak inspiratory pressure. This is the pressure which is responsible for the delivery of this tidal volume, of the preset tidal volume. So this is the driving pressure. This is very important. So this driving pressure is responsible for the delivery of the preset tidal volume. And here, this is when we look at this part, if you want to change the patient from volume to pressure control, if you can utilize this this driving pressure with the same resistance and same compliance of the patients will deliver the same tidal volume if you shift from volume control to the pressure control. So in this case, the driving pressure is totally from the ventilator itself. The patient has nothing to do. He's paralyzed. No effort for the patient. The driving pressure is determined by, as I mentioned before, by the preset tidal volume, inspiratory time, flow, and again its resistance and compliance. When you come to the matching the flow, for sure, this is the patient is paralyzed. He is not making any effort with on the ventilators. So the flow is that of the preset flow. Preset flow by the machine, by the physicians. Preset for the this is a preset flow, our flow. It's not the patient. The patient has nothing to do with the flow. The same thing for the volume. It is a preset volume. It is not there is nothing for the patient to do with this. For the patient is paralyzed. And inspiratory time, it is the preset inspiratory time, which is set by the physicians or RTA, or RT. This is it's important. This is what we call ventilator inspiratory time. This is ventilator inspiratory time. Should be considered. It has nothing to do with the patient inspiratory time. Oxygenation for sure depends on the level of beep and FI2. Advantages, this is usually we utilize this volume controlled mandatory ventilation in patients to unload the patient totally, in which the patient is paralyzed, there's no muscle relaxance, or the patient is unable, or the muscles are weak too much and cannot do an effort. In this case, we use this volume controlled mandatory ventilation, and there is a preset, the flow is preset, the volume is preset, inspiratory time is preset, and the oxygenation depends on the beep in of I2. By the way, this is the another mode which is assisted control ventilations, which is volume control. What will happen for this patient is if the patient is taking his breath. If the patient is taking a breath, he's going to trigger. Whenever he is going to trigger, the machine will deliver according to the preset tidal volume and flow. So the change here in the assisted control, that the rate will increase by the same figure, the same flow, same tidal volume. The patient has nothing to do. Well, look at it. So this is what about the interaction between the patient and the ventilator in this volume control ventilation in the assisted control. So look at this. Here, in case the workload, the driving pressure here is determined, as I mentioned before, by the peak pressures minus the PEEP. This driving pressure is responsible for the delivery of the preset tidal volume. But here, the driving pressure, when you look at the patient himself, he's doing, this is the respiratory rate. Look at this is the patient is triggering. So the driving pressure is fixed because it is the machine itself has nothing to do with the patient. Just the machine obeys the demand of the patient by triggering to deliver this press to deliver the preset tidal volume by the same flow. Look at it. Same flow, same inspiratory time of the machine, not of the patient. So the patient effort, whatever the patient made an effort by -3, -4, -centimeter water, and the patient is having some sort of any effort he is going to do will not do anything except triggering the machine. It will trigger the machine, but the effort of the patient will add nothing. Triggering the machine will deliver 500. If the patient wants to more than 500, he will never take except 500 from the ventilator. So this is a point of mismatching. The same for the flow. The flow is preset flow. It depends either IE ratio, which is changeable according to the IE ratio, or the or fixed flow. So the patient, the machine will deliver preset volume, preset flow, and the preset inspiratory time. If the patient wants more flow or less flow than that is delivered, he will do nothing except he will trigger, and after triggering, the flow will be delivered according to the preset flow of the ventilator. When it comes to the volume also, the volume, this is what will be delivered after triggering the tidal volume, which is the preset tidal volume, not the no increase or decrease from this tidal volume. And inspiratory time, this is a very important. This is there is in this volume controlled, assisted controlled, this is the patient triggers and the ventilator delivers by its preset flow, its preset tidal volume, its preset inspiratory time. So what about the patient? This is the ventilator inspiratory time. What about the patient inspiratory, which is neural inspiratory time? Maybe the same, or it may be smaller, or it may be larger. That's why this is some sort of mismatching. So we cannot guarantee that this is another problem should be solved when we are going to talk about adjustment of the ventilator. Oxygenation, for sure, this depends on the VO2 level of PEEP and so on. So in this case, assisted controlled from volume controlled ventilations, this is some sort of unloading, but this unloading, there is some sort of mismatching of the patient triggers, and the effort is delivered totally by the ventilator. But the effort of the patient has nothing to add except triggering. Flow is preset, volume is preset, inspector time is preset, and so the problem of mismatching is of high questions. The most important thing in this case of assisted control, volume controlled, this is it's very important. If the patient say the patient is paralyzed or under muscle relaxant and start to wake the patients and the patient start to take his breath, rapid breathing. Rapid breathing, this means that he is going to trigger and the tidal volume, the whole tidal volume will be delivered. So you have to take care. It's very important, especially patient with COPD, bronchial asthma, or ERDS, or even in normal patients, because in this case, the increase in the rate will be associated with encroachment on the expiratory time, and encroachment on the expiratory time will make a problem, will develop a problem of air trapping, which might lead to pneumothorax and tension pneumothorax. So you have to watch this and define what is the best, what is the maximum respiratory rate through studying the expiratory time constant of these patients, respiratory rate, the blood pressures, and keep it in mind, and you have to take care. Look at this. If the patient is having the respiration, this is a risk, but this is expirations, and this is expiratory pause. If the patient started to be tachypnea, so there is no the expiratory time, the expiration will decrease, and this is inspiratory time, and the expiration itself will not, the expiratory tidal volume will not be exhaled totally. So part of it will remain. This is the whole. This is a part of the expiratory time will remain. This means that the functions of the capacity will increase. So this is a normal after tachypnea. The tidal volume increase, so the blood pressure increase, more trapping, more increase in the blood pressures till it reaches to the critical point, which is 30 to 35, and then rupture of the lung and pneumothorax. And even with the presence of pneumothorax, the triggering also will make the machine to deliver the same tidal volume, not less. So tidal volume will be delivered on this case of pneumothorax to develop tension pneumothorax, and the patient might collapse. So this is a very important point when you are putting a patient on muscle relaxant and he's on mandatory and started to be assessed controlled. They are awakening the patients and the patients became tachypnea. You have to control yourself rapidly and take care that the patients might develop that pneumothorax. You have to take care of this point and you have to handle it. And thank you very much.